Now it's time for our sponsor perspective portion of the program, which is programmed and presented by our sponsor, the Coalition for Affordable Prescription Drugs. Please join me in welcoming on stage Tom Scully, Administrator of the Centers for Medicare and Medicaid Services from 2001 to 2004 under President George W. Bush, and Megan Scott, Executive Director of the Coalition for Affordable Prescription Drugs. Megan, over to you.
Great. Thank you, Johanna. Tom, thank you for being here today.
Sure.
I think we've got a great opportunity to really talk about some important issues. And given how much seems to be going wrong in healthcare and all the talk about what's not working, I thought maybe we'd start on a positive note. And from your perspective, what is working right now? What have you seen working in the private sector?
Not a hell of a lot in government.
Okay.
You know, in the private sector, you know, you've gone from when I was at CMS, now been a long time. I think when I got there, we had 4% of people in Medicaid managed care. Now it's probably 82%. Medicare plus choice, which for old guys used to be the name of Medicare Advantage. I think we had about 5% in 2001. Now it's 35%. So my view is largely the best thing that's happened is the government's stayed out of the way, and states, Democratic and Republican, have moved to capitation. It's much better than, my view, fee-for-service, you know, price setting. And that's happened in MA as well, and as the population ages a little more. So by nothing happening is bad, but the fact is the population is moving into more capitated, more efficient plans, and in a lot of ways that's good. And
how have you sort of seen the private sector move in to fill that need and sort of the absence of the government?
Well, I spent most of my time in New York with a private equity firm, so whether you like the ACA or not, it's been fabulous for healthcare investors because it's poured a ton of money into healthcare, and healthcare become popular. When I first started doing this in 2004, a lot of people avoided government programs, so there have been a lot of private investment, and obviously the public companies that are public have also done well, and that there's been a lot of money poured into healthcare. So you can discuss the policy benefits or shortcomings of that, but there's been a lot of, it's made healthcare an attractive place for private investment to go.
Yeah. You were obviously CMS administrator when...
I was the HICF administrator for like 3 days.
Yeah, there you go, until the big name change, the rebranding. But when Medicare modernization passed, you were there. Obviously, a key provision of that was Part D. Can you talk a little bit about the role that pharmacy benefit managers, the private sector, really have sort of played there? We know it's
Well, that was popular. The whole goal, and there's still a zealot in that. And some of the PBMs at the time didn't like it. So a couple of them, Medco and others who are friends of mine, did not participate. But the whole goal was to put them at risk. So one of my complaints, and I love the PBMs, but you know, they used to say, you don't understand our business. I said, yeah, I understand your business. You get fees on the front end from your ERISA clients, and you get rebates on the back end for the drug companies. The base costs are passed through. So we're going to give you $1,800 a year if you're wealthy, or $5,000 if you're poor, and say, call me next year. And magically, when their money was at risk, and they did a great job, generic utilization tripled in the first couple of years. And, you know, and it's exactly the same idea as Medicaid capitation or Medicare Advantage. If you take somebody on the taxpayers and put them at risk, magically and you say, you can make a 4% margin or a 5% margin, you get great results overnight because their cash is at risk. And that was pretty simple. So the PBMs delivered very well. We changed some of their incentives, which they didn't like at the time, but I think it worked. You know, at the time, for those who don't remember, I got hammered for Part D being a terrible, horrible thing. It was the end of the world as we know it. Lambert back there was working for me at CMS, so he remembers. So I scurried out of town, went to New York in 2004. Only come back occasionally, but you know, now people don't remember who passed it, and it's worked very well. And you know, the goal was to get seniors a drug benefit. So I started working here in 1980, and it's inconceivable now, but there was a hell of a long time I was here where seniors did not have a drug benefit. And that just wasn't right. So I'm proud of it. It was painful to pass.
Yeah, I was going to say, you took a lot of bullets at the time, but it appears to have paid off. Are there lessons that you learned sort of in the early days of Med D, or as we've sort of seen the evolution, that you think could be applied to other government programs?
Well, two things. People forget Medicare Part D was passed with Senator Kennedy was the key. Senator Frist, who's a good friend of mine, and I spent lots of time working on him. I think we had 11 Democrats vote for it the first time through in the Senate, and I think we ended up with 9. But, you know, it was under the circumstances, it was the beginning of an election cycle. You know, it was fairly bipartisan. And I'd say that was, you know, we spent a lot of time talking to the outside world. We got a lot of help from the PBMs in designing it. It wasn't exactly what they wanted, but we got a lot of input. And we spent a lot of time talking to Senator Wyden, you know, Senator Baucus, Senator Breaux, Senator Kennedy, and, you know, that doesn't happen a whole lot anymore, sadly, but I think the reality is you're always better off. I would have said that to President Obama in 2010. I would have in my view, found some way to pick off a couple Republicans to take the edge off it. And I think Republicans are finding the same thing now. So in the long run, healthcare is too big, the money's too big, the politics is too rough. Doing something on a purely party line vote just ends up in people jumping in trenches and throwing howitzers at each other, which is not a good thing.
Yeah. You've spent a lot of time talking about quality of care, value-based incentives. When you were at CMS, the agency started collecting this quality data, looking more closely at hospitals that were performing and weren't, and rewarding them accordingly.
Well, baby steps, a lot more has happened since then. It was pretty radical when we said, hey, we're paying every hospital in the country the same thing, and you can voluntarily give us quality measures. And if you don't want to volunteer, we'll voluntarily pay you 2% less. Yeah. Which is what we did. And they went nuts for a couple of years. But, you know, the fact is that's the right thing to do. I'm a rabid opponent of price fixing. So I love Medicare. I love CMS. The idea of people, as wonderful as they are, sitting in Baltimore or any other state, fixing prices by unit. And, you know, I helped invent RBRBS, sadly, in '89. It's crazy. And I've gotten away from that. So my view is I would prefer to take, you know, $15,000 a year for Medicare patient and give it to a Blue Cross plan, you know, so you're at risk, call me next year. I think it's a better result. So the fundamental issue with, you know, pay performance and paying somebody plus or minus 2% based on outcomes, it's okay. It's better than a sharp stick in the eye. Yeah. But in the long run, the government fixing prices on any system anywhere in the history of mankind doesn't work. And that's the fundamental problem we have is we got to get away from fee-for-service government price fixing. Right. I think history shows you it doesn't work. Yeah, it's now looking back sort of 14, 15 years, you see the costs going up sort of across healthcare and the prescription drug benefit. What do you see as sort of a feasible path forward toward this more value-based care? Well, drugs different. I mean, I think in the long run, the move towards well-regulated private plans. I mean, the system's a mess because, again, we still have 65% of people in Medicare fee-for-service. Yeah. We've got the different payment systems, Medicare, Medicaid, and private pay are totally disjointed, different incentives. If you're sitting there at a hospital, you get paid 60 cents on the dollar for Medicaid and maybe 99 for Medicare and 130 for commercial. I mean, the incentives are out of whack in the market. So at some point, probably not in my lifetime, it'd be nice to fix some of those things. On the drug side, you know, there's a lot of things you could do. You got a long way to fixing it, but trying to do it in a market-based way where you're not fixing prices again is tough. I would personally, this is my own bias, take Part D of Medicare, Part B of Medicare, which is a huge mess, and just put it in Part D. A lot of people wouldn't like that, but Part D works pretty well. And there's no such thing as Medicare Part B and Medicare Advantage. Magically, all the MA plans figure out how to pay for infused drugs, and it works pretty well. So I would do that tomorrow. The other thing that used to drive me crazy is I would have the FDA would approve a new drug, and then people show up at CMS and say, hey, FDA approved this, you got to pay for it. And I'd say, give me a break, you know, and then I'd try to talk to FDA, and they couldn't talk to you. So, you know, my view is if you show up at FDA with a new drug, they ought to have two tracks. If you want to come in and give us economic plans for the next 5 years of what you're going to charge and what the efficacy is and what the population base is, and won't torture you with examples, and you want to say, here's our plan for pricing and here's the population, we say, great, we'll put you on a fast track and you'll get approved in 6 months. If you don't want to do that, great. Yeah. You know, unless it's an incredibly important drug, you may wait a few years because you don't want to play ball. We'll take it really slow. So there are a lot of market-based ways that the government could change things. Now, I'm not running for things, so it's easier for me to say that. You get killed for doing those things. But, you know, there are two things that I would do. Okay. And sort of staying on the drug side of things, I mean, everybody knows that medical spending is outpacing general inflation, and prescription drug spending is outpacing even that. First, sort of, why is that happening? I mean, we see these gene-based therapies, and we understand that these are treatments we've not seen before. Well, you get more specific treatment. So, you know, whether it's, you know, the Hep C drugs, which are expensive, or cancer drugs, or you know, they're very specific drugs. They cost a lot to develop. I understand that. If my family had a problem like that, if I were Senator McCain, God bless him, or somebody else who had a serious disease, I mean, what's the right price to take care of somebody like that? So I think it's fabulous, the drug companies, and we develop all these wonderful drugs, but when you're developing a drug for a population of 6,000, it's going to be expensive, the return's going to be expensive. But we need to think through that. You shouldn't just be able to go make up a price and charge people $100,000. I mean, I'm a capitalist. I work for I'm a partner in a private equity firm. You know, if you're going to go out and invent a new drug, you should get a fair return for your investors for the risk they're taking. But you shouldn't be able to just go out and make something up, which is what happens. So how do you find the happy medium between that? It's not easy. Yeah.
So no easy solutions for us on that one, are we?
I can give you some, but I think we have 50 seconds left, and it would take me more than that.
Watching that clock closely, aren't you?
No, I mean, look, I had a couple drugs, radiopharmaceuticals, you're allowed to, there's some quirks in the law. You can actually, I had a couple of companies call up and they wanted us to pick a really high ASP, and I called them back and said, I'm not approving it. So you have to. I said, no, I don't. It's a radiopharmaceutical. And they, one case, I had IDEC Pharma, this is a long time ago, came in and spent 3 days with me explaining to me what their pricing was for Zevalin and how many patients there were and what the investment was. And, they came in, the original price was like $30,000 a dose. And I said, no freaking way, I'm not paying that. Yeah. And they came in and spent 3 days with us, and it turned out that the right risk-adjusted payment for that was probably like $22,000 a dose because it was such a small population. That's what we paid them. But there should be a process like that where people have to come in and explain what did your investors put in, what's the process, what's the risk you're taking. I mean, you want people to take a risk and develop these drugs. Yeah. You don't want people to just go out and make up a number because their marketing people thought that sounded good.
Right. And with that, I think you are
the 50 seconds
you are
right
off
there.
the hook. Yeah. Thank you, Tom. I appreciate it.
Yeah. Thanks
Go
for
back to
having me.
Johanna.
Great.
Thank you.